Then we are having a hospital registry which is ICMR recognized, and we are providing services for that. We run a definite headache clinic. In this, just now we are doing a clinical trial on neuromodulation in migraine using REM. That is a remote electrical neuromodulation in collaboration with Dr. ENT specialist Dr. Anita. And then we are having comprehensive pharmacological, non-pharmacological management is done. Yeah, Anita Banda. And it is we are doing one well. We have done about 20 cases. We just try a thing, and then this is the EMG and NCV lab as usual. We have recently established a video EEG lab which is functioning well, and we are trying to evaluate patients for pre-surgical checkup. Then these are publications. We have more than 100 publications in various national and international journals, and the recent ones I had 2 PhD students under me, and they have brought out real innovations, and we are going to get them registered also. Then we have got recently published articles in our national journal. Then this is another journal which is Pregnancy and Epilepsy Registry. This is the journal in our Annals of Indian Academy of Neurology. And then a word about public awareness program about epilepsy. We got a Mirgi Sabjo app. Then we got a helpline. Then we are regularly doing some posters and vans and I had also made a film on epilepsy. And then recently we are celebrating all the national and international epilepsy days. On the recent National Epilepsy Day in Seven, you were also there. We had Dr. Mendirata from GB Pant, in which we had a TV talk. First India had a TV talk, throughout India it went for awareness. And then we had a quiz program in which presents were given to the students. And then on International Epilepsy Day, Dr. Bhavana had come as a guest, and we had inaugurated our video lab. We also celebrated our World Stroke Day. And then recently, as the president of Indian Epilepsy Association, I held this Econ 2023, in which our students have won prizes, and these are the honors and awards the department has. And this is the Econ 2023, and then I was awarded the Bajoria Oration in this conference, which is a coveted oration, the 30-year Odyssey of Epilepsy Rural Camps, the Exotic Paradigmic Journey of Change. And this is the prizes were given. I would just like to make it out that in the quiz which was held in the Econ, one of our students, Dr. Madhu, who is going to present today, won the first prize in the Econ. And another student of mine, Dr. Ira, she won the third prize in the platform presentation, sir. So these were the, thank you very much, sir. And now I invite Dr. Yogesh to present the case today.
Very good morning to everybody. I am Dr. Yogesh Kaushik, presenting this CCR on behalf of Department of Neurology. And today's case is a 34-year-old male with tingling and numbness. So this patient is a 34-year-old male right-handed person, welder by occupation, studied till 10th class, a resident of Churu, presented with chief complaint of tingling and numbness in all 4 limbs for 4 months, intermittent episodes of palpitations and ghabrahat for 4 months, loss of bladder and bowel control for 4 months, blisters in both hands and soles for 3 months, intermittent episodes of bloating and vomiting for 1 week. So patient was apparently normal 4 months back when he developed tingling and numbness that was acute in onset, started as tingling in both lower limbs, and that rapidly progressed in both upper limbs in few hours, and that was followed by numbness in all limbs, back, abdomen and chest region, and since then it is static. Due to his numbness, patient had difficulty to feel the ground while walking. He was constantly looking down due to fear of fall. He had difficulty walking in a straight line. There is also history of slippage of slippers without awareness. He was unable to differentiate between hot and cold water below neck. Such was the severity that he used to put water on his face first while bathing to determine its temperature. He also had difficulty feeling things in his hand, for which he required support of one person for daily activities, and the numbness was associated with decreased sweating below neck region. Then patient had palpitations and ghabrahat since 4 months. That was intermittent, lasted for few minutes each time. It precipitated on standing. It was associated with profuse sweating on the face, few episodes of blurring of vision while walking, which resolved on sitting down. There was no history of chest pain or breathlessness. Patient also had loss of bowel and bladder control since 4 months. That initially he developed acute urinary retention, for which he got catheterized, and after removal of the catheter, he had difficulty in initiating micturition. There was poor stream, increased micturition frequency, there was decreased sensation of bladder fullness, and it was associated with decreased perianal sensation and erectile dysfunction. He also had constipation since the onset of his ailment. Then patient developed blisters since 3 months. They initially appeared on both palms and then they were noticed on both plantar aspects. They were painless, pus filled, appeared in crops, and they were not associated with itching. Then patient developed bloating and vomiting since last 7 days. That was the main complaint why he came to us, and that initially started as feeling of fullness post meal, and then patient developed multiple episodes of vomiting associated with nausea, which was non-bilious and contained food particles, and the vomitus was not blood tinged. The vomiting was associated with colicky pain abdomen, and that appeared transiently. Now coming to the negative history, there is no history of diplopia, ptosis, facial deviation, numbness, dysarthria or dysphagia, no history of limb weakness or stiffness, no history of weight loss, fever, decreased appetite, joint pains, oral ulcers, conjunctivitis, no history of neck trauma, no history of preceding vaccination, no history of seizures, loss of consciousness, behavioral abnormalities, no prior similar histories, no history of exposure to heavy metals, and no history of consumption of Ayurvedic drugs or chemotherapy drugs. So for these complaints, patient visited multiple OPDs. He was admitted in various different hospitals. He went to a physician who treated him symptomatically, gave vitamin supplements. Due to his ghabrat, he went to a cardiologist who performed angiography that came out as normal. For pain abdomen, he went to a gastroenterologist who did ultrasound and CCT abdomen, that also came out normal. He also visited a neurologist who did a MRI of whole spine, and that also came out normal, and he was started on steroids by the neurologist. But since the patient had no relief, so he came to Mahatma Gandhi Hospital. There is no history of diabetes, hypertension, tuberculosis or malignancy. He was a vegetarian, had adequate sleep. He was a chronic BD smoker with PACAS of 3. He is married and has 3 kids, and there is no similar history in the family. So to summarize, he is a 34-year-old male BD smoker with acute onset sensory and autonomic symptoms without obvious cranial nerves or motor involvement with palmoplantar blisters. So now the case is open to the house for any differentials they want to give. So based on this history, we could localize the lesion as a sensory neuropathy because the patient had acute onset. There was progressive course, distal to proximal. But the point against or what is not usually associated with neuropathy is early autonomic involvement. Then second is the neuronopathy, which is a disease of dorsal root ganglia, and all points were in favor. Acute onset, progressive course, atypical sensory loss pattern, or early autonomic involvement. There was a remote possibility of high cord lesion since there was a sensory level and bowel bladder involvement, but there was no limb weakness. So based on this history, we went for examination. So the general examination was grossly normal, except that patient had orthostatic hypotension. There was a fall of 40 millimeters of mercury. Yes.
Maybe you will be talking about it later, but we can ask the residents now whether they can differentiate. The medicine residents can tell me the difference between neuropathy and neuronopathy. Anybody volunteering? Because he has mentioned 2 things and he has distinguished the 2 things. So what is the difference between the 2 of them before he describes it? Anybody else from the medicine department or neurology?
Neurology knows the but will not explain. You have discussed only the localization. What about the etiology?
Sir, actually when we do a neurology history, first we have to localize the lesion and then think about the etiology.
History, what are the possible etiological?
So it can be a variant of sensory neuropathy. which is a variant of CIDP, chronic inflammatory demyelinating polyneuropathy. It could, since the patient had pain abdomen, it could be variegate porphyria, and obviously a neuronopathy disorder.
What are the aggravating factors your patient?
Sir,
the symptoms aggravate by taking some drugs?
No, sir, he was not taking any medication before the onset of his ailment.
Okay. I think with autonomic dysfunction and all those porphyric polyneuropathy should be considered.
Yes, sir, but porphyria usually have motor involvement. So,
yeah.
Yes, sir.
Just for my information, anybody having quadriplegia, will he have sensations of pain abdomen? Your patient had colic pain in
Sir, patient didn't have quadriparesis.
No, but just for my information, will he have pain?
Sir, if the sensory tract are preserved, he will have, sir. He can have pain abdomen. Since it is carried by various sensation, both parasympathetic and sympathetic.
Pain abdomen.
Yes, sir. So,
small fibers are spared, so then patient will have this pain abdomen sensation. If large fibers are involved, so in that case patient will have somatosensory this involvement, but will have sparing of the this small fiber sensations like pain, temperature.
So with this we did the CNS examination. His higher mental functions were normal, cranial nerves were normal, motor examination, bulk, tone, power was normal. All the deep tendon reflexes were lost. Coming to superficial reflexes, corneal and conjunctival were preserved bilaterally, abdominal was lost, cremasteric was absent bilaterally, and plantar was mute bilaterally. So coming to the gait, his gait, he has a high steppage, stamping his feet, putting the heels down first, and he was constantly looking down. So anybody want to describe what kind of gait it is? What can we name it? So this is a sensory ataxic gait. So coming to the sensory examination, patient had asymmetrical loss of touch, pain, temperature with distal more than proximal and left more than right. Vibration, joint position sense was also impaired, and Romberg's test was positive. Cortical sensation could not be elicited because the patient had problem in the primary modalities. There is no cerebellar signs. These are the various cerebellar signs we look for: dysdiadokinesia, dysarthria, ataxia, nystagmus, intention tremor, slurred speech, or hypotonia. There were no meningeal signs. There were no peripheral nerve thickening. So since patient had complaints of orthostatic hypotension, we did a bedside autonomic function test. These are the tests we do: deep breathing test, isometric exercise, cold pressure test, postural test, and all these revealed that patient had autonomic dysfunction, including both sympathetic and parasympathetic. So we did the other systemic examination, which was normal. Coming to the local examination, patient had these blisters, and they will be discussed by dermatology department. So now summarizing the patient, he is a 34-year-old male, BD smoker with acute onset sensory and autonomic symptoms, with asymmetrical sensory loss, areflexia, sensory ataxic gait, and signs of autonomic dysfunctions, without cranial nerves or motor involvement, with palmoplantar blisters. So now the case is again open to the house if anybody wants to give new differentials or want to rule out any previously told differential. So from here, Dr. Madhugandha will take the presentation forward. Thank you.
Good morning, respected teachers and my dear colleagues. I am Dr. Madhugandha Vahane from the Department of Neurology. So now, after discussing the history and examination, we can rule out high cord lesion because there were no UMN signs, there was no limb weakness, atypical sensory loss was present in this patient, and he has a previous normal MRI of whole spine. Now we are left with sensory neuropathy and neuronopathy. Next, I would like to begin our discussion about how we'll approach such a patient who is presenting with neuropathy or neuronopathy. This is called as a 3-6-10 approach, where we have three key goals. Where is the lesion, what is the cause of the lesion, and what is the possible therapy. This is adapted from Barron et al. And it is published in all major textbooks including Harrison. So in this, the first key goal is where is the lesion. For this, we have 6 questions. And I would like the participation from the audience for localizing the lesion. Our first question is, what systems are involved? Either it is motor, sensory, autonomic or combination? Can anyone answer? Yes. So there is involvement of sensory and autonomic system. Second, what is the distribution of weakness? Either it is focal or generalized, or it is distal or proximal, or it is asymmetric or symmetric. So I would like to highlight, this is asking about the distribution of weakness. So patient had no motor involvement, so he has no weakness. The third question is, what is the nature of sensory involvement? Either it is severe pain, burning or stabbing, or severe proprioceptive loss. So, yes, so the patient has severe proprioceptive and exteroceptive loss. The fourth question is there evidence of upper motor neuron involvement? No. What is the temporal evolution? Either it is acute less than 4 weeks, subacute 4 to 8 weeks, or chronic more than 8 weeks. Yes. So it is going in acute to chronic. Is there any history of preceding event, drug, toxin or vaccination? No. And sixth one, is there evidence of hereditary neuropathy, family history of skeletal deformity? As we discussed, it was no. So next, let's summarize in this slide. So the patient is having sensory and autonomic system involvement with no motor weakness, and he is having severe exteroceptive and proprioceptive loss with an acute onset. After localization, let's move to our next key goal. What is the cause of the lesion? For this, we did basic hematological and biochemistry of this patient, which was grossly normal. We did check for his vitamin B12, vitamin D, TSH and HbA1c, which was again normal. So now I open this question to the audience, that what else investigation would you like to do in this patient?
But before you move on to investigation, those blisters, are they part of the neurological illness, or are they pointing to a systemic disorder which involves the skin and the neural system both?
Yes, sir. So we had a strong suspicion about them, and we did took a dermatology reference, but for the sake of convenience, that we have integrated all the investigation first, and then we have included dermatological advice.
So they are not part of the neurological illness.
So we had a suspicion that they could be a part of neurological illness, because porphyria, as you know, is associated with blisterings like this. And apart from this, other neuropathic lesion can also have palmoplantar
No, I'm
blisters.
asking this question for the sake of the medicine residents, that if you have, as I said earlier, symptoms or signs which suggest 2 or more systems involvement, then you should start thinking of either a syndrome or a systemic illness rather than illness confined to one organ.
Yes, sir, definitely. So we also had a strong suspicion about it. So would you like, anyone would like to answer that? What investigation would you like to do in this patient? Okay. Yes. So we did do a nerve conduction study of this patient. His first NCV was actually done outside within few days of his symptom onset, and it was grossly normal. The second NCV was done almost 4 months after his symptom onset, and it shows absence of sensory action, nerve action potential in both upper as well as lower limb, which is suggestive of sensory axonal polyneuropathy. After this, because the patient had autonomic dysfunction, we did sympathetic skin response. It is an electrodermal response, and it is a non-invasive test which is done for autonomic nervous system testing. In this, so I would like to highlight that in this, normally there should be a formation of waveform like this. But in our patient, there was no waveform formation. So this goes in the favor that the patient had absent sympathetic skin response in both upper as well as lower limb. So this confirms with our finding of autonomic dysfunction. Coming to the key goal number 2, that what is the cause of the lesion? For this we had a list of causes actually, which these are the causes for neuropathy and these are the causes for neuronopathy. As you can see that it is quite an overlap between both of them. So we'll make a common table, and we did investigated all of them. So after our history and examination, we were able to rule out diabetes mellitus, and there was no history of any drugs. There was no family history, and the patient, because its onset and the disease progression was more than 4 weeks, so we ruled out Guillain-Barré syndrome. So we are finally left with these causes. To rule them out, we proceeded further. We did a CSF of this patient, which was suggestive of albuminocytological dissociation, and we did check for his viral marker. HIV, hepatitis B, hepatitis C, and VDRL was negative. The other tests which were done to rule out the secondary causes included autoimmune diseases. His ANA profile was done, and this is the report of it, which was negative again. The testing for Sjogren's disease was negative. P-ANCA and C-ANCA for vasculitis was again negative. Rheumatoid factor was negative, and serum angiotensin convertase enzyme level was again negative for sarcoidosis. We checked for heavy metal. It was a negative screen for arsenic, lead, mercury, and cadmium. And this is the investigation of heavy metal. This is a printed report. We did check for malignancy. For any occult malignancy, we did a PET scan for this patient, which showed no abnormal hypermetabolic area. And for paraproteinemic neuropathy, we did protein electrophoresis, which was again negative. We did check for 24-hour urinary porphobilinogen for porphyria, which was again negative. Because paraneoplastic diseases sometimes appear almost 1 to 2 years before manifestation of any malignancy, so we did a paraneoplastic panel for this patient, and it was again negative. Next, because the patient had palmoplasty blister and we had a strong suspicion that it is associated with neuropathy, so we took a dermatological consultation, and to discuss about it, I would like to invite Dr. Pearl. Thank you.
So good morning to one and all present here. So the patient was referred by the neurology department with sensory loss and palmoplantar blisters since the last 3 months. And on examination, it was multiple non-tender hemorrhagic to pus-filled bullous lesions of varying sizes, along with few hyperkeratotic crusted plaques which were present over bilateral palms and soles. So whenever a patient comes to the OPD with a blistering disorder, the following causative factors have to be ruled out. So first, there is no history of oral ulceration in this patient, and the area of the distribution of the lesion were not characteristic of any immunobullous disorder. Also on examination, there was a sparing of the oral and the genital mucosa, so we can rule out the immunobullous disorders. As there was no history of any ingestion of any drug preceding to the lesions, we can say that the drug causes are very unlikely. So as the sensory loss was also associated, there must be some underlying association with connective tissue disorders and vasculitis. So, and also the clinical lesions of vasculitis, including palpable purpura, like ulcerative lesions, which are very painful. So here we can rule out vasculitis like this, and also the ANA, the ANCA profiles are negative, which makes the vasculitis as a cause, being a cause, very less likely. There was no history of any topical application or contact with any drug or allergen, so we can say that dermatitis is very unlikely as a cause in this case. There was no history of any prodromal symptom preceding the lesion, and also there is no infective etiology amongst these, which fits into the clinical picture of the patient, except that of Hansen's disease. The patient was also non-diabetic, so we can also rule out diabetic bulla as a cause. So, under this clinical scenario, we can narrow down the differential diagnosis under 2 broad headings, namely porphyria and the trophic lesions. Although there was a history of abdominal complaints in the patient, but there was no history of photosensitivity and no lesions were present on the photo-exposed areas. There was no evidence of hypertrichosis and sclerodermal changes, and the urinary porphobilinogen was negative, which makes porphyria again very unlikely as a cause. So moving on to the trophic lesions. There was no skin lesion suggestive of Hansen's disease. The peripheral nerves were evaluated and they were not thickened. And the slit skin examination was done, slit skin smear, which was negative, and there were no acid-fast bacilli which were seen. So by these we can rule out clinically the 3 cardinal features of leprosy. But still we have to go for a skin biopsy to rule out leprosy completely in this case. Although after taking proper history and doing physical and neurological examination, the patient was counseled to avoid trauma, was given symptomatic treatment, and was advised to undergo a skin biopsy and a nerve biopsy by our department. So now I would like to invite Dr. Sonam Arya from the Department of Oncopathology to discuss the case further.
Good morning all the respected teachers and fellow colleagues. So grossly we received single skin tissue measuring 0.3 by 0.2 by 0.2 centimeter. On microscopic examination, skin biopsy showed normal epidermis and dermis with no evidence of vasculitis and no significant inflammation was there. For nerve biopsy, a section of sural nerve was removed. On gross examination, one nerve segment measuring 0.5 centimeter length was taken. Microscopic examination of nerve biopsy shows hyalinized epineurium with mild neovascularization. Perineurium show few thick-walled arterioles. Acute axonal breakdown seen. No onion bulb noted. No inflammation noted. K-pile stain for myelin shows sectorial loss of myelinated fibers with few regenerating clusters. Pearl stain for hemosiderin is negative. So the final impression is acute and chronic axonopathy of sural nerve. Thank you.
Thank you, Dr. Pearl and Dr. Sonam. So after this discussion, we were able to rule out all the possible causes, and we were able to complete a key goal 2. Now we took a step back to understand the pathology because behind the simultaneous appearance of sensory and autonomic symptom. Is it neuropathy or neuronopathy? That is the question again, and this is the core clinical features of neuropathy and neuronopathy, and these are the investigation findings which we normally find in any patient who is presenting with neuropathy or neuronopathy. The factors which were in favor of neuropathy were distal to proximal progression, but asymmetrical onset, non-length dependent progression, autonomic and bowel bladder system involvement was in favor of neuronopathy. Also, the investigation was suggestive of axonal loss in both nerve conduction study as well as biopsy, but we can find axonal loss in nerve conduction study in neuropathy also. So after this, we actually did an imaging of this patient to further localize between neuropathy and neuronopathy. For this, I would like to invite Vineet Mishra sir to take us further.
Good morning, respected seniors and dear colleagues. So this is the recent MR of this patient. On the left side is the T2 sagittal images, and on the left side is the sagittal stir images. On T2, the fluid as well as subcutaneous fat is bright, and on stir images, fluid is bright but fat is hypointense or black. So there is a slightly increased signal within the dorsal aspect of the cord as compared to the ventral aspect, and these findings were not well appreciated on the T2 sagittal images. So we have to look upon T2 axial images for confirmation. So this is the image of our case, and this is the image of a patient without significant abnormality in the cord. As you can see in the normal patient, the posterior surface of the cord is convex, and it is nearly homogeneously gray in shade without significantly raised intensity within it. Whereas in our case, the posterior surface of the cord appears slightly flat, as well as there is slight hyperintensity or bright signal within the dorsal column of the cord, and if we see carefully, we can see that the left half of the cord is slightly atrophic. These changes are better appreciated if we change the window settings. So these are the hyperintensity within dorsal column. There is flattening in the posterior cord surface, and there is relatively some relative volume loss in the left hemicord. These are the T2 weighted sagittal images through the dorsal root ganglion region. It's a two-dimensional study. We can see this is a normal patient and this is our case. In normal case, we can see the ganglions are well appreciated here, but in our case, the ganglions are not well appreciated and they appear relatively smaller and atrophic. Though it's a two-dimensional study, but we still have a strong suspicion that there is some volume loss of the dorsal root ganglion. These are the images of the dorsal spine. These are T2 sagittal images which revealed no significant abnormality, while in axial images we can see that there is slight increased signal within the dorsal column. Also the posterior cord surface is flat and there is some volume loss of the left hemicord. The hyperintensity in the dorsal cord was in continuous with the cervical cord hyperintensity and were extending up to D10-11 level distally, though conus was not involved. So considering that there is a long segmental hyperintensity within the dorsal column, and flattening of the cord surface and slight atrophy, we considered following differential diagnosis. The first commonest is the nutritional or the metabolic deficiencies or toxicities, in which the vitamin B12 deficiency is quite common, resulting in subacute combined cord degeneration. Others are copper deficiency, vitamin E deficiency, and methotrexate-induced myelopathy. However, cord atrophy is not common in these causes, so they were considered less likely. Another differential diagnosis of longitudinally extensive transverse myelitis was also less likely, as the hyperintensity in these cases are not usually restricted to dorsal column. They involve the central part of the cord, as well as they involve more than 2/3 of the cord transection in most of the cases. Among the infectious causes, HIV, vacuolar myelopathy, herpes virus myelitis, or neurosyphilis can involve the dorsal part of the cord, but these causes have already been ruled out by our neurology colleague. Among the inflammatory processes, sarcoidosis at times involve the dorsal part of the cord, but again serum ACE level were normal, so this was also considered less likely. Another important differential diagnosis is of sensory neuronopathy disorder, which is basically a primary degeneration or dysfunction of dorsal root ganglion and its projection, both central and peripheral one. Degeneration of central projections results in the hyperintensity in the dorsal columns, which is mainly because of myelomalacia, or in other words we can call it as Wallerian degeneration. This disorder is often associated with autoimmune disorders like SLE, Sjogren syndrome, sarcoidosis, autoimmune hepatitis and celiac disease. Other causes include paraneoplastic syndrome, neurotoxicity and infectious causes, and all these causes have already been ruled out, so we are left with possibility of idiopathic cause.
Thank you so much, sir. So this imaging actually helped us in precise localizing the lesion. After extensive workup and brainstorming, we made our final diagnosis. So this is a 34-year-old male with acute onset progressive asymmetrical sensory and autonomic system involvement with trophic ulcer. And the investigation supported by NCV with sensory axonal loss, MRI showing hyperintensities and loss of dorsal column, nerve biopsy showing acute on chronic axonopathy. So our final diagnosis for this patient is acute onset cryptogenic sensory and autonomic neuronopathy. So we applied the diagnostic criteria for neuronopathy in this patient, and this is given by Camdesens et al. And for this criteria A, we need a cutoff of more than 6.5. Our patient's cutoff was 9.2, and for criteria B, his initial NCS was normal and MRI showed high signals in posterior column of the spinal cord. So this fits the diagnostic criteria for neuronopathy. Now reaching towards the key goal number 3, which is the treatment of this patient. So the patient was started on pulse dose of IV methylprednisolone, and he was given IVIG 2 gram per kg of body weight divided over 5 days. And after this the progression halted. He was then started on oral prednisolone, and it was gradually tapered, and simultaneously he was started on azathioprine as immunomodulator and steroid sparing agent. He was managed with fludrocortisone for orthostatic hypotension and was advised for abnormal binder. He was rehabilitated with involvement of physiotherapy and occupational therapy. Next, I would like to invite Dr. Himanshu Kaushal to further elaborate about the pathophysiology and review of literature. Thank you.
Good morning, respected teachers and my fellow colleagues. As we have reached the diagnosis of acute cryptogenic sensory and autonomic neuronopathy, we'll be discussing further what these terminologies mean and what are the normal anatomy and what is the review of literature regarding this case. So as we know, this is the transverse section of the spinal cord with the grey matter in a broad H-shaped manner, and the white matter, the grey matter is lying within. This is the dorsal horn, and this is the ventral horn or the motor horn, and this is the intermediate horn. So as we all know, the dorsal horn is sensory and the ventral horn is motor, and the intermedial is divided into lateral and medial, that is for the autonomic system in the thoracolumbar outflow, mainly the sympathetic one. So as we know, the dorsal horn, it gives rise to multiple rootlets then join to form the dorsal root of the spinal nerve, and the another one is the ventral rootlets that join to form the ventral root of the spinal nerve, and they both join together to form the spinal nerve. So here in the dorsal root, there is pseudo-unipolar or the sensory ganglion or the dorsal root ganglion that lies in the dorsal root. So and this is the paravertebral sympathetic chain that carries the sympathetic ganglion. So what does a ganglion mean? A ganglion is a collection of cell bodies. So whenever the pathologies occur, they are named according to these affected structures. So first of all, when the rootlets are involved, this is known as radiculopathy. Second one, when the ganglia are involved, whether they are sensory, autonomic or both, these are known as ganglionopathy or neuronopathy. And when the nerves are involved, this is known as neuropathy. So coming to the patterns of insult or the degeneration patterns that we encounter in these cases, this is the normal physiological state in which the neuron resides. This is the cell body, this is the axon, and this is the myelin that is covering the axon by the Schwann cells, and this is the effector organ. So in myelinopathy, there occur degeneration of the myelin sheath. In axonopathy, there occur degeneration of the axon, and this is known as axonopathy. Whereas in neuronopathy, what happens? The cell body starts to degenerate, and as we all know, as described in 1950s by Augustus Waller, he described the Wallerian degeneration concept. The cell body degenerates. There occur retrograde and anterograde degeneration of the processes of the dorsal root ganglion, despite of any insult, being it autoimmune, being it toxic, being it metabolic, being it paraneoplastic or neoplastic. So Wallerian degeneration occurs in anterograde and retrograde pattern, and then on the basis of the causes of ganglionopathy, we divide the causes into three types. One are the two types, hereditary or acquired. Hereditary are hereditary sensory autonomic neuropathies, and acquired one are the acquired sensory ganglionopathies. These can be large fiber or small fiber, depending on the involvement of fibers on the sensory modalities affected. As we know, the dorsal root ganglion gives its proximal projections as well as the distal projections. Whenever Wallerian degeneration occurs, it occurs in anterograde as well as retrograde fashion. So there occur degeneration in the posterior column also. As we can see in our case, there was posterior cord hyperintensities. So we searched literature review regarding our case, and we found two major case series that were published in the literature. One was in the Brain Journal that was given by Keoki and group, and they discussed the clinicopathological features of acute autonomic and sensory neuropathies. What they described was the 21 patient case series that were having similar complaints as our patient had. They had severe autonomic dysfunction involving the digestive system, urinary system. They have orthostatic hypotension, mydriasis, hypohidrosis, sensory symptoms, and the loss of reflexes. So they described the patterns in their patients ranging from a complete sensory loss to a patchy involvement, to a glove stocking pattern that is often confused with neuropathy, to a segmental loss also. In our patient, we had an asymmetrical loss with a sensory level that was unique in our case. Second case series was given by Joel and group, and this was published in 2020, and they discussed three core cases that typically mimicked our case also. These cases had acute severe sensory autonomic deficit. The hallmark was sensory and autonomic neuronopathy. The patient was young adult. Patient had autonomic failure signs, and this was supported by nerve conduction study and spinal cord posterior cord hyperintensity in the spinal cord. So coming to the outcome part, in both these studies, what they have seen that the treatment options they were given was in the form of IVIG, plasma exchange, IV methylpred, oral steroids, and one received no treatment because the patient did not get any treatment. And they followed the patient for 2 years, one at the peak of onset of illness, one at 1 year of illness, and second year of illness. And what they did was they noted the orthostatic hypotension, nutrition, urethral catheterization requirement, and ultimately the disability was assessed using the modified Rankin scale. So what is modified Rankin scale? It is the scale that is used to detect the disability in patients with neurological disorder. Initially it was used for stroke, now it is used for neurological disorders. So we divide the scale into 0 to 6, 0 being no disability, 6 being dead, and within this these are 1 is mild, slight, 2 is mild, 3 and 4 are moderate without support, needing 1 or 2% support, moderate, 4 is requiring support, and 5th is bedridden patient. So in these case series, what they found that the disease has high morbidity and mortality. Out of 21, 3 patients died. 6 out of 21 were only had favorable outcome, that is they were ambulatory at the end of the course of illness. In our patient, what was the clinical outcome? Despite of significant pathological findings, patient is still ambulatory. There is no progression of disease, the disease has halted. The current MRS score of patient is 1. Patient is able to do his routine activities with slight disability in the form of sensory symptoms, and he has to look down while walking. What was the reason for this good clinical outcome was right and timely diagnosis, right and timely initiation of immunotherapy, regular follow-up and compliance to therapy in this patient. As we can see, the blisters has resolved. This finger got amputated because of trauma, but there was no history of blisters that recurred. This was the video sent by patient from his home. As we can see, patient can walk without support, but still has to look straight down to walk forward, but can able to do his daily activities. So coming to the conclusion part, acute cryptogenic sensory autonomic neuropathy is a rare disorder, and diagnosis of exclusion. We need to do a extensive workup before labeling the patient to have cryptogenic sensory autonomic neuropathy. Neuronopathy is a underdiagnosed and underreported condition. We need a high suspicion to suspect the patient having neuronopathies. Owing to its inexplicable symptoms and pattern of sensory loss, these may be labeled as functional neurological disorders. because they does not fit into a criteria of neuropathy or unexplained symptoms. Autoimmune, toxic and neoplastic causes should be ruled out in such cases who are suspected to have neuronopathies. So the take-home message is, neuronopathy is rare entity. There are only 25 cases reported worldwide in literature of acute sensory autonomic neuronopathy. It is often confused with neuropathy. One should know what is neuropathy and how it is different from neuronopathy. All the presentation can be same. Autonomic dysfunction in neuronopathy is very common. Disease carries a high morbidity and mortality if left untreated. Timely suspicion, diagnosis and adequate management is important for survival and better quality of life of the patient. And most importantly, a multidisciplinary approach and management is must for a good outcome. So I thank you all for attending this CCR. I would like to thank Professor Emeritus Dr. M.L. Swarankar sir, Chairperson Dr. Vikas Swarankar sir, President Dr. Sudhir Sajeev sir, CCR Review Committee, collaborating departments, the departments of Dermatology, Department of Radiology, Department of Pathology, and most importantly our electrophysiology team for their constant efforts and support. Thank you.
I think it's been a good presentation of a case which is probably one of a kind you have seen, or maybe the neurologist will see.
Yes,
but in the therapeutic part, you have mentioned that azathioprine has been used.
Yes, sir.
What made you think that it could be autoimmune?
So most of the, as we have searched the literature also, the most common cause behind this neuronopathy, despite of etiology, is the immune-mediated damage. Whether it is post-vaccinational, whether it is post-infectious, whether it is toxin-related, there occur formation of immune complexes against the cell, the antigen in the dorsal root ganglion. So it is advisable to go for steroids or IVIG in acute phase, and we can shift the patient to oral steroid followed by the steroid sparing agent in the form of azathioprine to halt the disease and to halt the progression further.
If you were to follow it up, and if you were to follow this patient like
yes,
other patients have been followed for 5 years or
yes,
3 years, whatever, do you think that any one of them can turn out to be a malignant case or a slow virus disease?
Yes, sir. Sir, as in literature,
slow virus disease has not been mentioned in your differential thought process.
So in slow virus diseases, the cerebral involvement is also more common. The patient can present with sleep disturbances. Patient have behavioral issues, neuropsychiatric features. They have also movement disorder in the form of myoclonus, dystonias. They are more common with slow virus diseases. But in paraneoplastic, the case is different. Sometimes 4 to 5 years even before occult malignancy is detected, patient can present with sensory ganglionopathies, and these need to be followed so that the timely treatment can be given and the progression can be further halted.
Okay, Hemant, can you tell us something about the paraneoplastic panel that's been mentioned?
So I am not very aware of the paraneoplastic panel. We just do a series of investigations, good examination and imaging to detect occult malignancies. But as you say, every time the patient comes for follow-up,
yes,
should be thoroughly examined from top to toe for any
yes,
new symptoms or signs,
yes,
right?
Sir. Yes,
and
sir.
if something is present, then relevant imaging investigation needs
yes,
to be done.
Yes, sir.
So any other, yes, Gaurav.